Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're now going to talk about acute pyelonephritis. We just talked about acute cystitis, but the difference is here in pyelonephritis, pyelo means pelvis, and nephritis refers to inflammation of the kidney. Now, remember in the previous video, we also broke this up into lower urinary system versus the upper urinary system. So we said the bladder and the urethra is our lower urinary tract, and then the kidneys plus the ureter is our upper urinary tract. So we said that cystitis was dealing with the bladder infection or inflammation of the bladder. Well, now we have to say that that bacteria has actually made its way up the ureter into the kidneys itself. And that is what pyelonephritis is. The pelvis is referring to the renal pelvis and the inflammation. So when we talk about the pathophysiology here, it starts fairly similar to what we saw in cystitis. So now we're saying that bacteria actually makes its way in through the urethra, then it can get into the bladder itself and colonize there, but it can continue making its way up the ureter, ultimately getting into the kidney. And because of this, we can see inflammation of the kidney along with interstitial neutrophil infiltration. And that is in part due to the fact that white blood cells will then come to the infected area, which is in the kidney in this instance. Now, when we look at the etiology here, there's a lot of similarities between acute cystitis because really pyelonephritis is more or less a continuation of cystitis that continuously made its way up the urinary tract system. If we catch it when it's in the bladder itself and we treat it, that's cystitis. If it continuously makes its way up to the kidneys, that becomes pyelonephritis, a much more concerning and severe condition. But the way that this occurs, the etiology primarily being the urinary tract infection, most commonly due to the same bug, E. coli, shares a lot of similarities with cystitis. Other things can also result in acute pyelonephritis as well, such as Staph saprophyticus, Klebsiella. This is not an exclusive list, right? There are other things that can lead to this, but these are some of the most commonly tested ones that I want you to know. Additionally, we also break this up into two primary different subcategories in terms of risk factors. We have anatomic risk factors and we have other risk factors. These are the same physiology as we saw in cystitis. So if you haven't checked out that video, I'd really recommend you go back and review that one to get more in-depth detail of the pathophysiology in these steps, but I'll just highlight the key ones here quickly. Again, the first is having female anatomy due to the shorter urethra, right? A shorter urethra makes it easier for bacteria to actually get into the body. They can enter right here and make their way into the bladder right here. That's not a very far distance to go. Versus with a male urethra, they would have a farther distance to travel to get to the bladder itself. This is decreasing the risk of having a UTI because the bacteria has to travel further to get there. Now, we also look at structural abnormalities, including BPH and VUR. BPH can cause an obstruction to urinary outflow. And so if we obstruct urinary outflow through the system, through the bladder, that leads to stasis of the urine, and this allows the bacteria to continuously ascend. Essentially, our urine flow, right, is actually preventative for bacteria ascending into the kidneys because it pushes it out. It flushes it out of the system. But if we have an obstruction, if we have a problem, if we have a vesicoureteral reflux, as discussed here, or BPH that causes a problem with this flow, this allows for bacteria to have a better chance to continuously work its way up the urinary tract system. Additionally, some other things that are important to consider include pregnancy, which is mainly due to the fact that there are a variety of different hormonal changes in pregnancy, and some of these changes can actually lead to venous stasis and a vesicoureteral reflux itself. And for the same reasons we've just mentioned, this can lead to a higher risk of UTI and cystitis, ultimately leading to pyelonephritis. Diabetes is unique because it's the fact that we have hyperglycemia in the body, which actually inhibits some of our white blood cell functions. The act of diapedesis, which is where the blood cells transfer from the vascular system into the kidney itself to fight the infection. And hyperglycemia can also inhibit the act of phagocytosis, where the white blood cells actually help clear the bacteria. And so people with diabetes are at higher risk because they have essentially impaired white blood cells. Additionally, anything that introduces potentially external bacteria inside the body can increase the risk of urinary tract infections, cystitis, and pyelonephritis, and these include things like sexual activity and the insertion of catheters. Now, when we talk about the presentation here, there are a lot of similarities with cystitis, but I want to focus on the differences here. So fever, flank pain, CVA tenderness. I would say these are systemic symptoms. And this is an important contrast because these are not typically seen in cystitis, right? If the infection is held within the bladder area, we don't typically see a fever. We don't typically see CVA tenderness. And so these are classic physical exam findings that can help you differentiate one versus the other. It's also important to note that pyelonephritis, right, if it makes its way into the kidney itself, we can see some other overlapping kidney pathologies, one of which is renal papillary necrosis. If you recall from a previous video, we said that renal papillary necrosis occurs from ischemia that leads to necrosis of the renal pyramids and the renal papilla. And one of the classic causes of this is acute pyelonephritis. And so that's an association I want you to keep in mind there. Now, when we talk about the diagnostics, we're really looking at similar things with cystitis. The best initial test, because of its rapid results, is going to be the urinalysis, in which we would see a positive leukocyte esterase indicating white blood cells and positive nitrites indicating gram-negative bacteria, which can convert nitrates into nitrites. This is not always going to be present, but it's commonly present. And why is that? Because the most common cause is the gram-negative E. coli. Additionally, some other things we can see include pyuria, which is white blood cells, and bacteriuria as well, which is actual bacteria in the urine sample. Now, again, another key differentiating factor from cystitis is the plus or minus white blood cell cast or hematuria. We would not typically expect to see these in cystitis because we are not dealing with kidney involvement. We're not dealing with glomerular or tubule involvement in the kidneys. The cast formation, if you recall, is a structural thing that occurs when there is a collection of cells that go through the tubule itself in the kidney and are ultimately excreted in the urine. So let's say we have inflammation and a bunch of white blood cells, I'm drawing here in kind of a light blue color, make their way to the tubules in the nephron. They enter into the tubule, do their thing to clear the infection, and ultimately they are compressed together, forming this urinary cast. So this will be excreted from the body, and we'll see this as a white blood cell cast. Now, this is not always present, which is why I put a plus or minus, but if you do see white blood cell cast, I want you to think about the fact that, oh, we see a cast, that means there must be an activation of the white blood cells in the kidney itself, in the tubules. That's the reason that we see the cast. It indicates there is involvement at the level of the nephron. Now, another key differentiating point I want you to remember is that we typically see an increase in serum white blood cell with pyelonephritis versus in cystitis. I said we typically don't see this, right? We typically see a normal serum white blood cell count, and the reason is because we don't typically see systemic symptoms with that pathology. But here we do. Here we have a fever. This is a systemic thing. And so it makes sense that our white blood cells would be elevated in our serum or throughout our body itself. Now, typically we don't need imaging for cystitis or pyelonephritis, but there is one particularly unique case, which is you should consider a CT image to assess for an abscess or an obstruction, which I put as not a routine thing. And the times that you would do this is if a patient is failing to respond to treatment. So you're treating them with antibiotics, it's not working, right? You would expect it to work given the appropriate medication and the appropriate dose. If it's not working, you essentially need to look for more information. Is there an abscess that's being walled off that you're not able to penetrate? Are there other things going on in terms of structural abnormalities? And so that's when you would consider getting an imaging for this condition. Now, moving on to the management options here, we're really going to focus on antibiotic treatment, right? So I want you to notice here that we're using fluoroquinolones for pyelonephritis. Compare this with the options that we used for cystitis, which was the TMP-SMX, the nitrofurantoin, and the fosfomycin. These are not strong enough medications for pyelonephritis. Once we get into the kidneys itself, we have to consider using our fluoroquinolones. A common one that they'll talk about is the use of ciprofloxacin. Now, same thing goes here for Candida-related infections. We're going to use an antifungal, the classic one being fluconazole. And again, for this to be the correct option, they would have to give you a variety of different clues that indicate we're not dealing with our classic bugs. We're not dealing with our E. coli. We're not dealing with our saprophyticus. They're going to have to give you enough clues to say, hey, this person actually has a Candida-related UTI. Now, a special case I want you to consider is that of pyelonephritis in pregnancy. This can be particularly high risk for the patient and the fetus. And so because of that, we're going to give these patients broad spectrum antibiotics plus a cephalosporin. And not only are we going to treat them with a variety of medications, these patients are also likely to be hospitalized. And again, the reason is because pyelonephritis in pregnancy comes with much higher risk than it would in an otherwise healthy patient who is not pregnant. And because of this, pregnant patients are actually often worked up for what's called asymptomatic bacteria, which is where they're not experiencing symptoms, but there's actually bacteria in the urine itself. Because if we see this, if we can catch this, they're going to get treated for that bacteria. And the reason is because of this will often become pyelonephritis in a patient who is pregnant. So we're trying to catch it and treat it prophylactically. Now, also high yield to remember that we want to avoid certain medications in pregnancy, including TMP-SMX and fluoroquinolones, because these are actually dangerous to the fetus itself. They can cause a variety of different complications. So we want to avoid those. We want to stick with our antibiotics, most commonly a cephalosporin. Now, as far as diagnosing these patients, we talked about the differences between cystitis and pyelonephritis. However, another key one that they could try to trick you with is that of pelvic inflammatory disease. Because a patient who has pelvic inflammatory disease can also present with some lower abdominal pains that we might see with bladder infections. They can also present with the systemic signs we would see in pyelonephritis, such as a fever, nausea, or vomiting. However, to tell the difference between those two, we really want to rely on our physical exam finding. So we talked about in pyelonephritis, we're dealing with a lot of CVA tenderness, which is kind of unique. But in pelvic inflammatory disease, although it would share, the fever, it's more likely to have something called cervical motion tenderness, which is severe pain with the pelvic exam itself. less likely to present with the CVA tenderness or the pain in the flank region, which is more likely to involve the kidneys, more likely to be the pyelonephritis. So a classic clinical vignette here could be something along the lines of a 27-year-old patient presents to the urgent care. They report that they've had painful urination and frequent urination for the last 3 to 4 days. They woke up this morning with a temperature of 101. They're starting to feel a little bit lethargic, have a little bit of malaise, and they might even tell you that the patient is 4 months pregnant. Now, we would want to work up this patient with both a physical exam as well as getting some labs, such as a urinalysis. And if the labs come back, we see that they're nitrite positive, they're leukocyte esterase positive, and on physical exam, palpation over the posterior flank region near the kidneys is eliciting pain for this patient. Well, we're most likely to be dealing with pyelonephritis at this point. Because this is a pregnant patient, they're likely to need hospitalization as well as their antibiotic treatment. And so again, the key here is that they're telling you the physical exam findings with the CVA tenderness, the flank pain. They're giving you some of the labs. All of these are indicative of a pyelonephritis versus some other conditions such as a cystitis or a pelvic inflammatory disease. So you want to use all the clues that you can to work through your differential diagnosis and think about what is most likely in this patient. So just a quick recap of this video, we're talking about pyelonephritis, pyelo meaning pelvis, nephritis meaning inflammation of the kidney. This is when bacteria ascends from the urethra all the way up to the kidney, not just to the bladder, but all the way to the kidney. You get inflammation as well as interstitial neutrophil infiltration. Similar etiologies as cystitis, it's commonly due to urinary tract infections, typically E. coli, and there are a variety of different anatomic and other risk factors that can predispose somebody to having this occur. They're going to present with a variety of different signs and symptoms, which I typically call systemic symptoms, right? So fever, malaise, lethargy, as well as some classic physical exam findings, such as CVA tenderness and flank pain. These are going to lead us to work up this patient by getting various labs, including a urinalysis, which is likely to show us, but not always, a positive leukocyte esterase, a positive nitrite, and potentially some white blood cell cast as well, indicating there's actual renal tubule involvement. We also want to keep in mind that to contrast this with cystitis, we're looking at typically elevated serum white blood cells because this is a systemic illness. Cystitis is more likely localized to the bladder, less likely to show increase in serum white blood cells. The management here is going to be antibiotics as well, but a different group of antibiotics. Now we're going to be dealing with fluoroquinolones, most likely ciprofloxacin, for the treatment of this, as well as the use of an antifungal if we're given information that we're dealing with a Candida-related UTI. Keep in mind the special patient population, which is pregnant patients who have this condition. If they have asymptomatic bacteriuria, we're going to treat them because of their risk of developing pyelonephritis is so high. If they do have pyelonephritis, we're oftentimes going to hospitalize them as well as giving them a variety of treatment options, but we want to avoid certain antibiotics in this patient population because they can actually cause problems for the fetus itself.